So, um, we can get started since it's 3 o'clock. Well, it's 3 Eastern time here.
Mm.
So I think over there in Central Time it's 2 p.m. But I will get us started. My name is Jeanette Lopez. I'm the chair for Health for All. We were formerly Minority Health, but we had to change our name. And our mission's still the same. It's to promote comprehensive health research and implementation efforts that address the full spectrum of health needs across populations. We are committed to generating knowledge that promotes accessibility, effective, and sustainable health solutions through collaborative research and dissemination, peer support for members, networking and mentorship opportunities, knowledge sharing, and continuous learning. Um, and we're very honored that we get to hear from Dr. Endine Santa Maria today. She is the keynote speaker for SNRS, so it is a privilege and an honor that we get to hear from her right before the conference. And then I will pass it on to Dr. Nita Matthew Joseph so she can introduce our guest speaker. And Nita is our co-chair for SNRS. For not SNRS, but for our RIG.
Thank you, Dr. Janet Lopez. Hello and good afternoon to everyone. On behalf of our SNRS Health for All RIG, I am delighted and honored to welcome Dr. Diane Santamaria as the speaker of our first webinar. She is the current dean and the professor at the University of Texas Health Science Center at Houston Cizik School of Nursing. She received her bachelor's degree in nursing from Ohio State University, her master's degree in public health nursing from Case Western Reserve University, and her doctorate in public health from UT Health Houston School of Public Health. She is a former visiting professor at the University of California, San Francisco Center for AIDS Prevention Studies also. Dean Dr. Santa Maria has expertise in public health nursing, adolescent health, HIV, sexually transmitted diseases, early pregnancy prevention, intervention development, randomized control trials, mobile technology, and predictive modeling. With wide range of experience working in underserved communities in the US and abroad, she is currently leading two NIH-funded RO1 RCTs that test the efficacy of mHealth, enhanced nurse case management, and just-in-time adaptation, HIV prevention, and care coordination intervention among youth aged 16 to 25 experiencing homelessness. She is also leading an NIH-funded R34 study to co-design a post-sexual assault HIV prevention intervention for youth and young adults. She is currently serving as a director of Developmental Core of Texas Developmental C4 and co-director of Substance Use Scientific Working Group. She has received numerous international, national, and state level awards and honors in recognition of her contribution to the nursing profession, including Sigma's International Nurse Research Hall of the Fame and Lucy Bradley Springer Excellence in HIV Prevention Award from the Association of Nurses in AIDS Care. Now, without further ado, please join me welcoming our first speaker, Dean Dr. Diane Santamaria.
Hey everyone. Thank you so much, Neetha and group, for inviting me. I'm super excited about this. And I was charged with talking about all of the research that I've been conducting thus far, and then also talking about all the lessons learned along the way. So it's a tall order for just a couple of minutes. So I'll be just lightly touching on the topics that were asked of me, including the various research projects. And then hopefully at the end, we will have some time for questions. I would love to get to know more about this group. I've done a lot with SNRS, but not so much with this group. So I'm really excited to hear about your mission and the great work that you do. So let me turn my emails off because otherwise you're going to hear nothing but dings. A day in the life of a dean. Okay, can you see the screen there?
Yes.
Okay. All right. So I challenged myself with coming up with everything I've done to date on one slide and try to figure out how do you make sense of it all? Where does it intersect and where does it go? And for me, this was important because I think you can quickly compartmentalize all of the various topics that you're working on. And so you've got to figure out how to make sure it all gels together and that you keep your eye on the prize along the way because there's just so many steps that it takes to be able to do any of this work. So I'm just going to start off with this upper left-hand corner here. And I had the great privilege of working with Vincent Guglielmo Ramos right out of the gate. So I started off as an assistant professor in 2013, and somebody really smart was mentoring me and said, you know, one of the best ways to get started is to make small iterations to an already existing evidence-based intervention. And that spoke to me. So I cold called Vincent one Friday afternoon and said, "Hey, what do you think about?" He was working on this project called Families Talking Together, which is what I had done for my dissertation. And I said, "What do you think about adding an HPV component to that?" And then not only that, but taking it out of the clinic where it had originally been tested and testing it in after school programs with parents of kids in under-resourced communities. And then on top of that, what if we train student nurses to do this? So that when they're working on their community health nursing coursework, they're actually implementing an evidence-based intervention in the community. And so he was all game for that. And so we put in this grant, and there used to be a mechanism that we were eligible for called an R15, which I have to say is the best kept secret. Very few schools are actually eligible for it anymore. But it was a small amount of money over 3 years where you could do an intervention. And because students were the ones that were the interventionists, it was cost effective to be able to use that model. So we ran a full randomized controlled trial on $150,000 with over 500 parents over a 3-year period and found that we could, in 30 minutes, a student nurse was effective at changing the HPV vaccination uptake and completion for high-risk groups of young people. So that really sort of taught me that you can do a lot with a little. And was very grateful to have the mentorship of Vincent along the way to help figure out how to do this. And then, of course, the support of the dean and all the amazing students that went through that program because it showed student nurses who are now all out in practice that the conversations you have with parents, even though they may be overwhelmed, even though they may not seem like they're always listening because they've got a whole lot of things going on, they can be impactful. And that was a lesson that we took along the way and really started to build into all the other research I was doing. But at the time, I was coming into contact with a lot of families who were sort of non-traditional families, young people who were in the foster care system, who had sort of temporary families that were taking care of them, and then really started to think about what does this look like for kids who don't have parents? And that was a big shift for me. So I did not work with young people who are experiencing homelessness during my dissertation, but quickly started to work on that over the next couple of years. And I knew I had a lot of work to do because first, our institution back, 12 years ago had not done much with this very, very marginalized population. And so all the way down to the IRB was skeptical, right? So NIH is skeptical that you're going to be able to do it. IRB is skeptical that you're going to be able to keep people safe. And so there was a lot of work that we had to do to create really meaningful partnerships and to, really lay some evidence-based strategies to how we are going to be able to do this work. And so there was all that front work was so incredibly important. And honestly, I can say there is no way I would have been able to do the work that we've been able to do without spending the time to get that right. And that meant I was taking nursing students to shelters that served young people since 2009. I spent 5 years giving to those shelters and doing everything I could to help them before I asked for my first letter of support. And now I've probably asked for 100 letters of support since then. But, they really needed to know that I was going to show up and that I wasn't going to be that cliche where you come in, you grab the data, you publish the paper, you get tenured, and you never come back, right? And they had seen that happen before, and that's why they were so skeptical of academics. And so I had to demonstrate that that was not my intentions and I was here to stay. So then I started working on all these other projects for young people who were homeless. And the first project we did was this high rise homeless youth risk and resilience survey. And this all happened from a phone call. Somebody made a phone call to a faculty member at the school public health who didn't have the bandwidth. And so he said, well, I know Diane's been working with young people. So I connected with this national group across 7 different cities, and we had no money. So zero money in any of we were all assistant professors. And we said, well, we can spend the next 2 years trying to get money to do this project, or we can just do it. And so we all opted in to just do it. And that meant a lot of hard work, a lot of weekends, a lot of evenings. But what we wanted to accomplish was to do a national level survey of young people to be able to figure out what was happening with youth experiencing homelessness across the nation. And from that really pivotal project came everything else. Everything else I worked on has been data driven from those initial conversations of what's the issue, right? That's where we found out that young people who are being raped, 30% of them are being raped while homeless, not ever in their life, while homeless within the last 12 months. And only 29% of them are getting any care after that. That's where we found out that there was very little understanding or awareness of PrEP or pre-exposure prophylaxis or post-exposure prophylaxis for that matter. That's where we found out that substance use, what does the substance use landscape and patterns look like in this population? And then that's where we found out that stress and urge management or urge surfing were really low in this population. So as you sort of move over to the middle of this slide, it all focused around HIV. HIV risk is something that allows, by focusing on HIV, it allows you to consider all of these other factors that are so incredibly important to this population. And, there's those 4 circles around HIV risk. It would take all of us our lifetime to be able to solve all these problems, but it gives you a good strategy so that you can continuously try to figure out how do I make things better for people, right? I can't solve all of the issues that have led to their homelessness, but there are things that I can do that will help them be able to exit homelessness without an unplanned pregnancy, without worsening mental illness or substance use, and without a chronic condition that they have to now manage the rest of their lives. So when you think of HIV risk, right, you have all those behavioral risk factors that come into play, either things that they engage in or things that happen to them that increase their risk profile, right? So that could be higher rates of condomless sex, it could be trade sex, it could be human trafficking, it could be rape and assault. Then you move over to you have your access to healthcare. We live in Texas. We didn't expand Medicaid. So this is a population that, for the most part, is completely uninsured, has no access to healthcare, unless they have, perhaps they're not completely disengaged from their parents, and maybe their parent is still working and they have access to that healthcare being under 26. That's a possibility. But you also have how they've engaged in healthcare their entire lives. That can be a major barrier. So when you grow up in poverty, when you grow up in these various situations that a lot of young people come to the streets from, they have never engaged in healthcare in a way that allows for prevention to happen, right? It's always an emergency situation. So if you break your arm, if you chip your tooth, those are the things you're going to get access to healthcare for. Not, I'm feeling well, I'm going to my well visit, I'm going to talk about vaccines and, what's your nutrition like? Those things were not normal. So it's very difficult then to think about how am I going to engage in healthcare as an adult, a young adult, when that's just not something I ever experienced. Then, of course, you have population prevalence, which this varies across the country. But here in Houston, we're considered one of the 50 counties, the 48 counties that account for over 50% of all the new HIV cases every single year. So we're considered a high risk population because we have more than 1% of our population has HIV. And so that means that a young person is going to be more likely to come into contact with somebody who has HIV when they're sexually active. And then we've got all of these provider barriers that we just have not been able to solve just yet, right? We're pretty bad at doing a sexual history. We tend to stigmatize and bias populations. So we've got providers who I will get a young person to come to them for PrEP, and the person won't disclose that they're having high risk sexual activity. Or the provider will say, well, this guy's homeless, so he's got too much going on for me to start talking about PrEP. And they gatekeep access to prevention services that we know work when they are available and accessible. So we've got a lot of work to do on all four of these spheres if we're going to make progress in HIV risk. And to put it in perspective, this population has about 16 times the likelihood of getting HIV as their housed peers. So the risk is dramatic. And almost every marginalized population that's represented within our nation is overrepresented in a homeless population. So all that to say is we took all this information and over the last several years have been gracious enough to have funding from NINR and NIDA to be able to conduct some of this work, as well as NCCIH, and the early FTT work was NICHD. So I'm going to just briefly talk about these interventions, and then we can sort of go into what I think were some of the key reasons why we were able to be successful against all, I would have to say against all odds, because a lot of this work has happened in the era of COVID, so it's been extremely challenging. So as I mentioned, this first project, right, this was an easy twist on an already effective product that we knew could be helpful to parents. So we were able to expand setting, we were able to expand who the facilitators were by using student nurses, and we were able to expand not only on parent-child adolescent sexual health, but also adolescent vaccinations. And we did that by partnering with a local hospital here, Texas Children's, who already had a mobile clinic. So we were not only able to educate parents, what we would do is when parents were in car line to come pick up their kids from these various under-resourced schools, or we'd meet them at the Boys and Girls Clubs after schools, we were able to connect with them and make it as easy as possible for them to access the intervention by going to them in the places that they go on their regular routine day. So instead of having people come to us, we went to them, and that was extremely helpful. And then in addition to that, we would have vaccine clinics come to them in these various locations so that their young person could get vaccinated with all the adolescent vaccines, not just HPV. And so we were able to see a really nice increase in HPV uptake and then completion in this group, and not just for girls, but also for boys, which is fantastic. That one was funded by NICHD, and again, it was this mechanism called an R15, which is a great mechanism, but not available to most schools anymore. This is the group of nursing students that we had, just one of the groups. I had two groups of 10 go through this project for a series of years. So we had 90 students who were trained to become facilitators of families talking together plus HPV. And then also they were trained in a nutrition program. So that served as the control condition. And so they got nutrition training to be able to talk with the parents of young adolescents. So that was my first real study that was complex and had lots of moving parts and never enough money, and you make it work. And we were so thrilled to be able to offer that to students. And many papers have come from that, including one of the interesting aspects we were looking at was the preparation of the student nurses, right? So how can we prepare them to be able to administer and a strong vaccine endorsement with confidence and competence? And so that was one of the other things that we looked at for that study. And then, as I mentioned with the high-rise study, this is where I actually sort of infiltrated, it was a social group, a social worker group. So they were all social workers in these 7 cities across the country. That's how they all knew each other. And one of my colleagues was a social worker, and she mentioned this study, and I said, well, that would be, do you think they would be open to me adding some health questions on, sexual assault, HIV risk, PrEP, all those other things? And she said, absolutely. So we designed this really, really fantastic cross-sectional study to be able to look at that across the 7 different cities. And these are the cities that were represented in that study. And we're still working together. In fact, I have a doctoral student who's still waiting on one of her papers that came from this, that was looking at parenting adults and parenting young people who are homeless, who have their kids, and those who don't have their kids, and what does that look like for their mental health and well-being. And then, I was very fortunate to be funded by NINR, and super grateful. This was during the time when Rebecca Henry was with NINR and really pushed this application forward. So I can never thank her enough. And actually, I was awarded the PCASE award from this study. So that's the Presidential Early Career award for scientists and engineers. There's only 4 nurses that have been able to get that, and it was from this study back in 2019 that it was formed from. And so, really excited about this study. We wanted to figure out if nurse case management could work for this population, right? So this is a group of young people, as you can imagine, that have a lot of things going on, right? So they've got mental health concerns, substance use, they're not housed, all those sorts of things. So, of course, challenging, right? But we did it anyway. So we built a nurse case management model called Kaya, Come As You Are, and we're able to partner with an amazing group of co-investigators on this, including Addie Namathi, who is out at she's at Irvine now. And she had done a lot of nurse case management in older populations, but not in young people, and not primarily focused on HIV. So the important part of why we believe this intervention was effective is because it's based on motivational interviewing and nurse and shared decision making. And those are 2 critical aspects for populations that experience issues with mistrust, because they allow for the person, whether that's a patient or a client, to be in charge of what's going to happen in this intervention, right? And so for Kaya, what that meant was that a young person was able to choose from a menu of various HIV prevention strategies, and they could select what made the most sense for them, right? So not everybody was interested in getting on PrEP. Not everybody was interested in using condoms. Not everybody was interested in committing to sober sex, right? So only having sex when you're not high. So they could select with the nurse. The nurse met with them for 6 sessions. And in those sessions, in true nurse case management style, they focus on a variety of different aspects. So they looked at mental health, they looked at housing facility, they looked at stability for housing and job market, and substance use, in addition to all the things they were doing for HIV. So we enrolled 450 young people. Again, this was funded in 2019, and you know what happened in 2020. So really challenging to be able to manage a randomized controlled trial, especially at a time where access to the population and access to the organizations that were serving them was extremely modified. So we had to pivot at certain times to only doing these interventions over phone calls if because the shelters occasionally would shut down because they were, on sort of infection containment strategies. So we had to constantly pivot. But we were able to do it. We enrolled 450 young people and had some really good results, increases in PrEP, which are fantastic. But we saw that not only did we have an increase in PrEP, but we had a increase in PrEP use and adherence over time, meaning that even for those young people who didn't choose PrEP as their goal at the beginning, 9 months out from the intervention, they were more likely to get on PrEP than the control condition. But even more fascinating than that was that we found that they also moved from a riskier state to a healthier state overall, meaning that the young people that were in the intervention group were more likely to have stable housing, less reported anxiety and depression, more reported stability in work, and were also had outcomes on HIV prevention and substance use. So we were really happy about that. And as you can see, we've got a bunch of papers that have come out of there, but we also have these other topics here that we're still exploring because, again, this is a longitudinal study with 450 young people who are homeless. So we want to be able to use that data as much as we possibly can so we can reduce the burden on data collection for this population in general. So there's still a lot of data that we collected that we're able to look at, including experiences of intimate partner violence, substance use over time, et cetera, et cetera. So those things are all in the works. And here are some of the papers that have come out of that study. And so, oops, what'd I do? Okay. I was fortunate again, thank goodness, to get funding from NINR a second time for a randomized controlled trial called MyRide. So this is a study that we're conducting now, and it's based off of, again, all that information that we started to collect many years ago. First looking at qualitative measures and then cross-sectional studies, and then we started to follow people over time and get longitudinal data. And then we started to use methods called ecological momentary assessments, which, were led to the ability to create a predictive model that would allow us to predict the days that a young person is most likely to engage in sexual risk behaviors. So we did that from a prior study that was internally funded by one of our wonderful partners grants that we have here at the school. And so we followed young people for 21 days, 100 young people, and we were able to determine that on the days that they are stressed, that they have urge for sex, urge to use drugs, the day that they do use drugs, they're more likely to have sex than the days that they don't. So then we use that information to develop MyRide. So what my ride does is it uses EMA and it's what's called a just-in-time adaptive intervention. So we ask young people these really brief surveys, take about a minute to complete, and they get them 3 times a day, and then we can based on their factors, determine whether or not they are at risk. So if they are at risk, they get specific messages pushed to them, and if they're not at risk, they get neutral messages like "Have a great day," "You're doing great today," those sorts of things. So this meant that we had to develop these messages. So using the information, motivation, and behavioral model theory, we were able to develop all of these various buckets of messages. And then we took those to young people to rank order and to revise so that it's in youth speak, right? So it doesn't sound like a 40-year-old white woman talking to you about sex, right? Like, how would you say this to your friend? And then that's the kind of messages that they get. So they're very relevant, very salient to a young person. We're in the middle of this trial. We have 320 people that we are enrolling, and we have about 280 as of this morning already enrolled. So we're super excited about that. And we will be following up to see whether or not there's a difference in, of course, between the intervention group and the control group on, whether they have STIs, HIV, of course, HIV risk behaviors, and then looking at all those other factors that play into that, like housing stability, substance use, and so forth. And you can see off here on the lower right-hand corner that there's a behavioral interface that they are able to access. So they can monitor their success in reaching their goal at any given time on the intervention. And they can also, as you see up here in the upper left-hand corner, they can call a nurse or a staff member at any given time to be able to ask for, I had risky sex this weekend. Where can I go to get testing? Those sorts of things. So we're hoping to wrap up that study early next year, and really excited because it'll give us 2 options. If it is efficacious, it'll give us 2 options to potentially roll out in an implementation science intervention grant to determine how we can get Kaya and MyRide to various young people across the country so that they have access to HIV prevention. And here are some of the different papers that have come from that study to date. So just this year, I was able to receive funding from NIDA to, this is an R34, which if you've never had an R34, they're fantastic. They're really great mechanisms that allow you to actually develop an intervention and then pilot test it. So this one goes back to all the reasons we were looking at for why don't young people receive care after being sexually assaulted, because it's a huge missed opportunity for not only counseling and connection to various therapies that may help them to heal, but also pregnancy prevention, HIV prevention, and prevention of STIs. So we knew that young people were not accessing doxypep, which could prevent chlamydia, gonorrhea, and syphilis. We're not accessing NPEP, which could prevent HIV. And many of them knew about Plan B for pregnancy prevention, but they weren't accessing that either. So we wanted to figure out what we could do that would potentially modify that. And we opened this one up to all adolescents and young adults, not just those who are experiencing homelessness. And then maybe in later iterations, we will specifically modify or adapt it for that population. But we're partnering with an organization here in Texas, which is very innovative, and they provide sexual assault services to a young person wherever they are. So it can bypass going to the emergency department, which is where a lot of young people are sent, because that's where they can access a sexual assault nurse examiner. But it's oftentimes an inappropriate place to go unless you've been strangled or have a physical injury, because you're considered the walking well, and you can literally sit in the emergency department long enough that all of these medications that would be efficacious are now losing their efficacy because you waited too long to take them. So this is just the beginning of this R34. So it's in the planning phases where we're working with survivors as well as key informants on actually designing and testing this intervention. So that one is more to come over the next 2 years here. And here's some of the earlier work that we've done that lay the groundwork for why this kind of intervention was needed. And then here is a study that this was another R34 that I received. This one was from NCCIH. And it was again using that model of let's find out what an effective intervention and then see if we can make modifications to it for this population. So using an intervention called DOT-B, which is out of the UK and has a lot of efficacy trials related to it for kids who are incarcerated, kids who are in juvenile justice, and then school-based kids, but wasn't really adapted for young people who are in a shelter. And in addition, it was meant to be sort of given over a school year. So you had 10 long sessions, and it took months and months to deliver the full intervention. So we took this R34 and created DOT-B for me, which is a modification of DOT-B that approximates the length of time that a young person is in a shelter, and then also creates an intervention that's much more salient to the population. So we were, really excited about having the opportunity to do that. And we ran a trial here in Houston and saw some really good feasibility outcomes from that. So we have a pending grant with NCCIH that will it's a different kind of mechanism. It's an R01, but it's a 3-year R01 and it's a 3-year feasibility R01. So we're going to use that to potentially be able to run a feasibility trial in Houston, Atlanta, and New Orleans and determine whether or not we have not only the ability to recruit in all those areas across a multi-site study, but can we then follow young people up? So more to come on that if that R01 gets funded next year. And here are some of the publications that have come out of that .B for me work. Okay, so I don't know if I can make you guys any bigger, but I can't quite see you, so you'll have to unmute if you want to talk about any of these points. But I put together just some of the lessons I've learned along the way, and believe me, I'm a kid in school for the rest of my life, so I'm always learning what works and doesn't work, and it's not always something that worked yesterday or pre-COVID may not work anymore. So you have to constantly be learning and adapting to make this kind of work, especially in populations that are made vulnerable. In order to be able to continue to do that work, you've got to always be a school, somebody in school, always be learning. So I think one of the takeaways that I've found is that it really takes about 3 years to get an R01. So, and that some people would say that's a little bit fast. But I think that if you're really strategic, you can get it done in about 3 years. And the reason it takes that long is you've got to create a scenario where you have established all those collaborations that you're going to need, right? You want to be able to show a track record of having published with these folks, having worked with these folks before, because part of selling your idea on any grant is that you're showing and convincing others that it's feasible to do the work and that you are able to do the work. And so you've got to be very convincing. In order to be convincing, the most compelling thing is data. So when you have prior work together, it's a data point that you have been able to successfully get things across the finish line. So that's where that prep time comes in trying to figure out, do I know enough to know what the real problem is here? So I know what to focus on, right? And you saw all those early studies and how that all played into what I was going to focus on in the future. And then do I have the team and have I created that narrative around our ability to do this work and why we should be funded for this kind of work. So that takes time. Those are the prep years. But in order to do that, you have to know where you want to be in 3 years because you're going to have to figure out where are my gaps and who's the person that can fill my gap so that we can create a cohesive team that's comprehensive but not overlapping, right? And so you got to work backwards a long time to be able to figure out who that group can be. And then that gives you time because you know it takes absolutely forever, even longer now to get published, right? Your paper sits somewhere for 9 months before you find out any details on it. So because of that lag time, you don't want to go into a grant application and have no manuscripts. Or just be able to see manuscripts under review. So you need to be able to give yourself some time to have those things pop up and be searchable so that people can and look, and then you can always cite yourself on that earlier work because you need to create that narrative that first I did this and that's why we're working on this and this is what's worked in the past and this hasn't worked in the past and that's why we've got to do this thing a little different over here. And then it takes forever to be able to get your application together. So I usually, if I can, if the stars align and I've got time, then I give myself 6 months to be able to prepare an application. Now, if it's like a P30 grant, which we just put in this year, we give ourselves a year. We're working on that application a full year as a team before we put that in. But you also have to be agile enough, like the R34 that dropped from NIDA, it dropped over the summer, and we only had about 6 weeks to respond to it. So that's a very tight turnaround, right? Because basically everything's due 2 weeks before it's due. So in addition to that, both myself and the MPI were going to be on vacation at different times during that 4 weeks that we had left to be able to build out this full grant. But because we had so much data and we had given it so much thought, it came together and we were able to get funded on that first round. So some things just align because you already had done so much work and you already knew what you were going to do, and then the mechanism comes out and it's just perfectly aligned. So some of those things also happen. You've got to be willing to, drop whatever it is you were going to work on that month and put something else together. So, I think the work that I do can be very mentally challenging. I hear a lot of stories of young people, and it's, that moral injury is a very real thing. So I think you've got to always be careful to stay engaged with your why, whatever that why is for you. Because when you don't get a grant, and I remember earlier in my career, you'd get rejected for grants, and that was the normal process, right? You put it in and it doesn't get discussed, and then, it gets better over time. And I was getting sort of burned out from the rejection, and somebody who was mentoring me said, this is going to be hard to hear, but there's still going to be homeless young kids next year and the year after and the year after. And yes, I know you feel bad that you're not going to be able to intervene with the kids that are on the street today, but if you burn yourself out, you're not going to be there for the kids that are going to still be on the street 10 years from now. So, it's, I think, continuing to remind yourself why you're doing this work, because when the going gets tough, you've got to remember, a lot of times if you stop doing this work, there's nobody else who's going to pick this up. There's nobody else who's going to be able to do the work that you're doing. So it's important that you invest in yourself and you understand the bigger picture, that it's really not about you. It's about the work, and it's about, trying to help people who you just happen to be in a good position to hopefully help. I think the other big thing for me that's been very important is trying to make sure that I'm a good partner to our community partners, because we ask a lot of our community partners, right? We ask them to write letters of support and get it back to us by the end of the day. We ask them to let us come into their facilities, and we don't oftentimes give them any sort of reimbursement for all the times that we've gone there, the lights we use, the desk we use, et cetera, et cetera. And in addition to that, it takes forever for research to have results. So it's a very slow moving clock. And for organizations, they don't always understand, oh, I'm writing a letter of support for you for a grant that's going to go in January, and you're not going to hear until December, and then we won't start working until the next January. That how can I even sign with any confidence? I have no idea what next year is going to look like, right? So it's about trying to figure out how to create a scenario where you can give people small wins along the way so that you're continuing to contribute as a citizen to your community partner while you wait for some of these things that take a lot longer to brew. So for me, what that means is anytime I'm collecting data, I'm asking my community partner, what would be most meaningful to you? What is it that you worry about when young people get discharged from here that you don't know? Did they ever do this? Were they ever able to get tested? Did they ever start HIV treatment? Like those are the things I can ask, and then I can report back to you so that you can start to iterate and create some quality improvements along the way. So those sorts of wins help to make the long road of getting these grants a little bit easier for people to swallow. And then, of course, it creates a scenario where they know you're in it for the right reasons, and that you're going to do everything you can on your side to help their organization. And then, really trying to figure out how to write a grant can be tough. And we all know that, right? I'm dean. I'm refuse to give up my research. I will not give up my research. My organization, my institution's extremely supportive of that. But I understand that could be different in other places, right? Where maybe you get into an admin role and then you're told, you shouldn't be doing research. In our organization, and I think this is something that I hope nursing picks up in general, because so many of us are going to get tapped earlier in our careers at younger ages and at earlier stages of our career. If we start giving up our research to become administrators, then all of our nurse scientists are going to go away because the people who get tapped are the people who have the R01s. And so that's a problem, right? So it's my obligation to be able to role model what does it look like to be able to be a successful dean or a successful associate dean or et cetera, while also still conducting my research and meaningful research that, is difficult to do. And yes, it requires a big team to be able to do those sorts of things. But it's incredibly important that we as a nursing community model that, because otherwise we will have a stripping away of all of our nurse scientists as they start to, especially with the looming retirements that we have coming up. So it takes a long time to write a grant. You've got to get the data that you need. You've got to be compelling. You've got to gather all of that idea phase, and you have to have people that you can talk to along the way. We have what's called an HIV think tank here that we hold at least once a month, and people bring their very early ideas. Oh, I was thinking about this the other day. And then they also bring much more cooked ideas, and we try to help each other through that. So you've got to have somebody that you're willing to just bat ideas around with. And you need to have a framework because sometimes this work can feel messy and a little bit disjointed, right? Especially like I mentioned, I'm working on HIV, but that also means mental health. That also means substance use. That also means housing, right? So unless you create a framework that people can understand how that all works together, it's going to be very difficult to sell your idea. So that framework is probably one of the most critical components. And you need to put that framework in front of your brother and your mom at Thanksgiving and say, do you understand what I'm trying to say? Because you need to have it be that clear. It has to be that clear to people and to your reviewers. You've got to be really good at taking criticism and not thinking of it as, a personal attack, but as a, gratitude. Thank you so much for spending so much time looking at this, that you've found this little nuance that's going to make it so much more impactful. Like that, those are gems, those are gifts that people give us along the way. So be open to criticism. The worst kind of feedback you can give is this looks great. Fingers crossed, right? Sometimes that's warranted if you've seen it 15 times, right? But if you see that on your first round, be skeptical. And then I think, always making sure that you're asking the right questions, that it's compelling, and because the landscape changes as we've seen over this last year. So you have to make sure that you are being able to be responsive to what is compelling, what is the salient health problem that you're working on. Okay, so I will stop there and see if there's any questions or conversation.
There is one chat comment. Dear Dr. Maria, thank you very much for sharing your excellent studies. You are doing excellent job. Very impressive. Thanks a lot for your presentation. Ping Ming Ye. Please feel free to ask questions if this is the discussion time.
Hi, I have no question, but great presentation. Great to see you here, Dr. Dean Santa Maria. And the topic is very meaningful, the research you have done, and very great insights on your advocacy on how to move forward with research for nurse scientists. So thank you.
Thank you all for coming.
Does anybody have any questions? You could either chat or unmute yourself. Dr. Santa Maria, I really enjoyed your presentation as well. I really appreciate your resilience and flexibility and adaptability. I feel like the times that we're living now, this is something new for many people. Do you have any advice of how to kind of start being more flexible and pivoting? We keep hearing that word everywhere we go. I think last year at SNRS, they're like, we're pivoting, and it's just like any words that you can provide, or how to just be open and change, because that you seem to be doing that a lot in your work. You were, you didn't let nothing stop you. You just worked with what you had, or that this wasn't the time and you waited. So
Yeah, I think that's the key, is having a little bit of breath in what you do, right? So if you've got, one chicken and you're waiting for that one chicken to become the prize, you could be waiting a long, long time. But if you've got various things that you're working on, some of them are going to brew faster than others. Like the mindfulness work, I have been doing that since 2013, right? It took me till 2021 to get that funded. Now, granted, there was a whole bunch of other things going on, like deaning and the COVID and all, but um, but I never let a good idea die. So I'm very committed to the data and understanding that letting that drive my commitment. So I mean, the NIH knows I will come back to you 4, 5, 6 times until I get funded. Um, so it just depends, because it's not always about you or your idea. Sometimes, like you said, it's the timing. So firearm research is a really great example of what unfortunately happened. Is it became unfundable, and we lost a whole cohort, a whole sort of generation of firearm researchers. And then now we're at the place where we're trying to build that back up again, because they did pivot. And what would have been a better approach is if people didn't pivot, but they sort of worked on other things that are tangentially related, that would still allow their work to move forward when the things change again, because they always change.
Thank you. I think Sandra has her hand up if you want to ask your question.
Yes, I'm Sandy Anneman. I'm not a member of this rig. I'm a member of the biological rig. Um, but I I work with Dr. Santa Maria and have for years, and I'm here to attest that she is a paragon of commitment and persistence. And those two attributes that are required to have a sustained research program are not that common. So, I mean, you can't be a fragile little flower and feel hurt if things don't get funded and what have you. But I wonder if Dr. Santa Maria could has any special tips for faculty or practitioners or anybody who really wants to have a program of research rather than a discrete study. Uh, what options might exist when you're in a low resource, low research intensive school versus one that's high resource? It seems that it could be a larger struggle to get access to all manner of, with people, with potential team members, with um, pilot study money. Do you have anything special for those faculty who might be in a low research intensive, low resource school?
Yeah, well, and Sandy, I am a fragile little flower some days, so but you get back up and you do the next thing the next day. So, but thank you for that. Um, I think it's challenging, but that's that's why I brought up that high rise study very purposefully. I've done several of those kinds of studies, but I wanted to illustrate that there was seven of us that came across the country, had $0, and still pulled off a sample size of 1,400 youth experiencing homelessness, the largest up to that time, and that we had so much data from that. We've gotten like 25 papers and maybe 8 or 9 grants that have come from that cross-sectional study that was completely unfunded. So there are ways to do that, especially if you're at an institution where you're an early stage investigator and you have protected time. That protected time, you have to think of every hour is worth 2 hours of your life. Like that time is so absolutely critical to maximize what it is you're going to do with that protected time. And a lot of studies do not require significant amount of resources to be able to gather data. You can do qualitative work, you can work on secondary data analyses. So all of those things continue to build your trajectory and help you answer questions. And I think to your second point, um, there's two things that I've seen have been effective for people to have sort of long careers in research. And one is that you focus solely on the problem, right? Whether that's heart disease or whatnot, right? You focus solely on the problem, not the solution, because I think the people who focus on the solution tend to find that they have difficulties with that. But if you focus on the problem, the health problem, that seems to work very well and allow you to be able to pivot over time. And then the other one is you focus on the population so that you can focus on various health concerns of a specific population over time. Those two strategies can give you a lot of flexibility in being able to pivot or modify how you're going to work on something over a given time.
That's probably good advice for doctoral students too, for PhD students. Anybody actually who wants to get something understood by the masses. Good advice. Thank you.
Yeah, I do think there's all it's so we're nurses, right? So we're doers. And so sometimes we get stuck in the doing. And when we get focused on an intervention or we get focused on a solution, then you're going to time limit yourself. So it's always trying to remember to focus back on the actual health problem or the population that you're serving.
Thank you, Dr. Santa Maria. Do you have any more questions? We have 1 more minute. Now, I would like to invite Dr. Janet Lopez for giving the vote of thanks.
Thank you, Dr. Santamaria. This was very great and inspiring. Um, I am, sitting and like reflecting and taking a lot of stuff of your advice in, and I really feel grateful for all of us in this space, and that we get to listen to you. And I think somebody said that you have commitment. In I see that, and I think that is very inspiring, and even in the work I'm doing now, and I think everybody here. So just thank you for your time, and I hope everybody has a happy holidays. And thank you. So
Thank you guys so much. And thank you for all the work you all do.
Thank you,
See you in
everyone. Have a
February, right?
wonderful Thanksgiving. Thank you, Dr. Santa Maria.
I'm gonna stop recording.